Okay, hello everybody. This is Terry from the Premom team hosting today. I'm super excited to be sharing this time with Nurse Linda, Steph Kagan, and Dr. Haebe. Thank you ladies for joining us today. We're going to start by taking some time for each of them to talk a little bit about their experience with unexplained fertility while trying to conceive naturally, their perspective of it, and then we're going to answer some questions that you gave us ahead of time, as well as I see that there are already some questions in the Q&A that we'll also answer. So let's start with Nurse Linda.
Hi, good morning. I wish I could see all you little faces out there, but I'll just imagine. I'm glad you guys joined us. I'm sure we'll be very helpful to you guys today. A little bit about me. I'm a registered nurse, and I've been an infertility nurse for over 20 years now. I was actively working with Dr. Jeffrey Scher at Scher Institute during that whole time. Opened up some clinics around the country, from California back to New York. Now I'm kind of leading a boring life. Well, actually, I like it. I work from home, and I do fertility coaching and videos, a lot of Nurse Linda videos on YouTube. What else? I was in a documentary that was really exciting called Vegas Baby that talked a lot about mostly IVF and that kind of thing. My background is mostly clinical in more interventional fertility work. So IUIs, IVFs, third-party parenting, donor eggs, surrogacy, et cetera, genetic testing, embryos. So my field is a little bit stronger in that. Topic today is unexplained fertility. What do we think about that? So my thought on that is that doesn't exist. Unexplained infertility just means we haven't figured it out yet. That's what that means. If it exists at all, by the way. Sometimes because we can't get pregnant for, 6 to 8 months, we think we have a fertility issue. And we might not. It might just be that it hasn't been time yet. The sperm and egg situation hasn't worked out in such a way that it's caused us to get pregnant, but nothing's wrong. Nothing's broken. We're not infertile. The timing hasn't worked out just yet. Other times, obviously, there are very real reasons why there are fertility issues. And certainly after attempting to try for a year, if you're under 35, for example, and you're not successful and you've been following Premom type of activities and luteal phases and ovulation, and if it hasn't happened, then something is going on. But to say unexplained infertility really just means we haven't figured it out yet. There's an answer. It's male, it's female, it's both. Something's going on. So I don't like to settle on infertility, unexplained infertility. That's my hit on that, and that's my background. I think that's it for now.
Thank you. Let's continue with Steph Kagan.
Hey everyone, I'm Steph. I am a women's health nurse practitioner. I have been working in the field of reproductive medicine as well for about 5 to 6 years now. I work in a fertility clinic, so again, kind of similar to Nurse Linda. I work with patients going through IVF, Clomid, letrozole, inseminations, that kind of thing, where we do very evidence-based evaluations with blood draws and labs and things like that. And I've seen a few of the questions pop up about side effects in Clomid and IVF, and we can definitely tackle those in the future during this webinar here. But I have spent the last 5 years really helping women understand kind of what's going on with their bodies from a very holistic level to a very scientific level. I do think there's a huge gap that some are not putting those together. So it's really nice with Premom, you get to learn a little bit of your body more at home instead of just throwing you right into the science-based stuff if you were to walk into our fertility clinic. I was a labor and delivery nurse first, so I've kind of seen both ends of the whole baby world. So this is my life is women's health. I specialize in nutrition as well for women. I did a project when I got my master's, my thesis on the impact of nutrition on reproductive health. So I've looked at things like soy, how, hormones and phytoestrogens can impact endometriosis, inflammation in your body, things like that. So to me, unexplained infertility, I do agree with Nurse Linda that we kind of haven't found the right answer yet. Unfortunately, unfortunately, about 30 to 40% of infertility can be male related. And often we spend a year looking at the female partner prior to even looking at the male. So it's important if you're early in your journey, I think, to really make sure your partner is healthy, make sure that, you know, he gets a semen analysis and things like that. The best thing you can do for yourself if you're struggling with unexplained infertility is to boost your health the best you can. That might be mild exercise, reducing inflammation in your body. That can come from whatever's important to you culturally, whether it's meditation or going for a 30-minute walk every day, really just reducing inflammation and cortisol and other hormone levels. So when you think about our cycle, it's not just your estrogen and your progesterone. There are so many different hormones that all impact each other, your thyroid, your cortisol, your sleep patterns, all of those things add up to make how fertile you are. Of course, as Nurse Linda said, there are very, very clear things that could cause infertility, like your tubes are blocked or your husband has no sperm or things like that. But when we're talking specifically about unexplained infertility, usually there's a few different variables, and our job is to start looking at all of those variables from A to Z and say, okay, it's not A, it's not B, it's not C, and trying to rule things out so that way we can narrow down what could be causing that problem. If you really think about, you know, fertility, somebody in their peak fertility who is super healthy and doing everything right only has about a 20 to 25% chance of conception each month. So, you know, it takes a long time to keep rolling those dice over and over again until we really, you know, make that perfect embryo, and that embryo implants and all the stars align. So I just, you know, anyone who's out there that's listening, don't give up, hang in there. Get you as healthy as possible. So that's my take on unexplained infertility, is, you know, working on inflammation, your whole health, and science with, I love science, but really kind of looking at the whole picture.
Great. Thank you, Steph. And last, Dr. Haebe, please share your take on unexplained infertility.
Hi, everyone. If you guys are from the Facebook group, I've probably seen you around a little bit chatting lately. I'm Dr. Patti Haebe. I'm a naturopathic doctor, and I'm also the medical advisor for Premom. I have a focus in my practice, my private practice, on fertility and hormone optimization, as well as general wellness. But I've been working with Premom for the past year to help kind of launch this virtual consultation feature and really help connect fertility specialists with you for whatever your needs are. I started using Premom personally a few years ago, years and years ago, really, for period tracking everything, and then a few years ago for actually trying to conceive. So I've been on both sides of the fence on that with you guys. But yeah, I couldn't agree with Nurse Linda and Stephanie more. Hit the nail on the head. We're missing something. What piece are we still missing? What do we still need to investigate? And you know, it is that, you know, focus on optimizing egg quality, endometrial lining, sperm quality. What autoimmune diseases are we missing? What clotting disorders are at play that we haven't looked into yet? How can we lower the toxic burden of your body and exposures? You know, what food allergens? So just, you know, focusing on all that. And then also, I think this is something you guys would agree with as well, is, you know, a lot of people come in and they say, oh, I've had all the lab testing done. And I always say, grab a copy of your labs, because we have truly run all the labs. And not only have we run all the labs, but are they in optimal ranges? Sure, you might not be in the red zone, but are you in that happy optimal spot? So a lot of times unexplained fertility is that stamped diagnosis of exclusion, and it just means that we need to dig a little. And also, it's so funny you just mentioned the fertility, you know, there's everything perfect of conceive cycle. And I think that's such an important to keep in mind, and why it's so important to stay consistent with cycle mapping and tracking, because even when everything is perfect, we still only have that, you know, small percentage chance to conceive per cycle. So I love that point. And I think it's very empowering and kind of helps us all calm down a little bit in this exciting process of conception. So I'll call it there.
All right, let's jump into the questions. And first, we're going to start with the questions that you gave us ahead of time, community. And the first one we're going to give to Nurse Linda. And it is, when it comes to sperm, is a gelatin consistency a concern? It happens here and there.
All right, well, that's easy. No. Nope. Their sperm will clot up. It will be gelatinous. That's normal. When it comes time to do its job and swim to that egg, it's got all kinds of nice cervical mucus to go through. That does a lot of chemical things to it to make it better, make them better swimmers, etc. So no, not a problem at all.
Okay, great. Now we're going to switch to Steph. Steph, the next question from my male partner. How do you support your spouse and empathize with her hormones during treatment she's going through?
Yeah, so this is a great question. And I actually talk to a lot of our patients. We try and spend about equal time talking science and talking mental and emotional health as well. No one sees themselves in the position of wanting to have a baby and then needing to go down this road. So one thing that I would really recommend for partners who are listening is to really just understand that not only is it a hard time in general, but everyone is also newly adjusting to this idea that it is the way that they're going to have to make a baby. Unfortunately, everyone thinks they're just going to try at home and be pregnant and everything will be great. And unfortunately, that's just not the way the world works. And sometimes, I talk to my patients about, being empathetic, and for male partners, they truly can't, empathize accurately because they can't understand what those hormones are doing. But when people are taking fertility medications or even going through cycles, your estrogen levels can get 3-4 times of what they would be in a natural cycle. Typically per follicle, you make about 200 picograms, nanograms of estrogen. When you're going through an IVF cycle or anything else, that level may be upwards of 4,000 or 5,000. So we're talking about tenfold of the normal hormones that your partner is normally, carrying. So that's really important to keep in mind is they're not just mentally losing it or feeling emotional or having a bad day. They are they're making 20 eggs in a month when we usually make 1 egg in a month. So, from that perspective, and then from a natural perspective, even when you're trying at home, if you're not taking these fertility medications, it's a lot for, unfortunately, we've gotten ourselves into a position where womanhood is defined by motherhood, and that doesn't need to be the case anymore. If a woman chooses not to have kids, or if a woman is unable to have kids or struggling to have kids, that doesn't define her as a woman. So I think it's really important that for your partner, whether you're in a same-sex situation or for your spouse who's, completely different hormonally from you, that you just need to give them space and let them realize that not only are they going to take some time to accept it, nobody anticipates the struggle. So it's shocking on all ends. So the best thing you can do for your partner is to really just listen and try and be as open-minded as possible. I think the best quality you can have in life is to be adaptable when a situation changes, to be able to adapt and approach that situation with a new mindset. So for the male partner that asked that question, I think you just try and take a step back if they're feeling emotional or upset or angry. All of those different feelings are normal and they should be validated. One of the best things you can say to your partner, and it's the same thing as when you're talking to toddlers, is I see that you're upset. I see that you're frustrated. I hear that you are sad. Because when you acknowledge those feelings, it allows that partner to feel validated, to feel real. Like, okay, somebody knows that I'm sad. Somebody knows that I'm upset. So first, always acknowledge their feelings. Make sure that your partner knows that those feelings are seen and heard. The best thing you can do is to make your partner feel seen and secure and safe and like they're in a comfortable space at home to be able to talk about everything.
Wonderful. Thank you. All right, we're going to switch over to Dr. Haebe for this next question. It's kind of related, I think, to the previous question, except more from the female side. The question is, how do you deal with the anxiety of the wait and just wanting to enjoy the present?
It's so tough, right? I think the most important thing here is, obviously everybody says be patient, but just, I think, even if we look at the data and having realistic expectations, just like we were just emphasizing before. I mean, for everything to go right at the peak of fertility, we're looking at 25 to 25% fecundability per cycle, which is likelihood of conception per cycle. So I think what's really important is I feel like all you ever hear about is the people that got pregnant on the first try. And you feel like when you're ready to start, trying and having a baby, you're ready to get pregnant that first cycle. You're only hearing about, 1 in 4 people really who got pregnant that first time. That's not necessarily the norm. It's just what we hear about. And I think it's important to just keep that perspective. And, while I am a huge advocate for investigating your body and, not wasting time looking into things, making sure that you are optimizing your body's conditions to host that successful pregnancy, it's also important to enjoy this process. This is a time for you and your partner to bond, and it's not a timeline. It's just naturally what's supposed to happen, and just that sitting back and letting it happen. So I would say having realistic expectations, not focusing on other stories that you're hearing, and just really focusing on you and nurturing your relationship and nurturing your body through that time.
Wonderful. Thank you. I just wanted to plug really quickly. I don't know if you did, Dr. Haebe, but we do have a partnership with a program called Organic Conceptions.
Mm-hmm.
Called Organic Conceptions, and they help a lot with these last 2 questions that you asked. They have a wonderful program that can be done solo or as couples. All right. And now we're going to switch back to Nurse Linda. Okay, first question. Is there really no explanation? I think you kind of answered that part for unexplained fertility. And should we visit a geneticist or endocrinologist?
Okay. So, no, I don't believe there's no explanation. There's always an explanation, right? We may not always get to it or find it right away, but there is always an explanation. Should we visit a geneticist or endocrinologist? So, there are issues sometimes genetically. A couple of things. If somebody has more than 3 miscarriages, for example, there can be genetic issues such as what are called balanced translocation, where getting a karyotype on both partners to make sure that there's not an issue going on genetically there. Also, there are plenty of genetic diseases that could cause a problem, not necessarily with infertility, but of course, we always want to make sure we have a healthy baby. So a geneticist is going to be important when we need to look into some further things. It isn't something right out of the box we have to do. And again, I know they say under 35, try at home for a year, over 35, try 6 months. And again, at home means doing things like Premom and these apps and being a lot more in control versus, a date night and a glass of wine once a week. You've got to be a little bit more assertive sometimes and more in control over how you're going to get pregnant. As for reproductive endocrinologist, which is the kind of MD that you usually see when you need to have more invasive treatments. Again, a lot of that depends on your age. Anytime after 35, I would encourage starting to get some assistance, just simply because time is running out. We don't have as much time as we did when we were 28. So when you're 35, and especially if you're working on your first child and you've always wanted to have 2 or 3, then you probably need to step it up a little bit. And a reproductive endocrinologist is going to be the kind of doctor you're going to see for IVF treatments and this kind of. You can still stay lower level with GYNs if you're just doing some inseminations or timed intercourse with some oral medications. And again, but certainly you're going to try at home with Premom app and ovulation predictor sticks and all that kind of thing first. So not right out of the box do you want to see those things, but those are all there down the road that I hope you don't have to investigate, but they are part of the investigation when things aren't going our way.
Okay, great. Thank you. The next question touches a little bit, I think, on what Dr. Haebe was talking to, a little more specific. It says TTC 2+ years, second round of Clomid, next is IUI. How do you deal with the stress and the unknown?
Is that me again? Right?
Oh, yes, this is you for couple.
Okay, sorry. Okay. Well, let's see. All right, trying to conceive for 2 years on second round of Clomid. Next is IUI. Okay, well, these things, certainly doing IUIs is going to increase your chances. Don't know your age. That would be relevant. But how do we deal with the stress and the unknown? So first, acknowledge the stress. And as Steph said earlier, the truth is women most often are losing their mind when they're going through this. That's actually very normal. It's very, very scary to go through this and not be in control and always have this fear hanging over you if you're ever going to be a parent. That's huge. And by the way, I'm not even mentioning the thousands and thousands of dollars you may have to spend to investigate this and even just try to get a baby. So you can line all these things up and realize they should make you lose it sometimes. That's very normal. Mostly what I've taught my patients is really understand the very little control you have over things. Certainly when you get into more aggressive treatments such as IVF or even IUIs, you worry about, can I have intercourse? Can I still go on walks? Can I, go up the stairs? Can I carry my groceries and all of these kind of things? And part of that problem is we as the medical community put that on patients because back in the old days, we used to actually put all of these limits on patients who were doing infertility treatments, where we would scare them into thinking they really had control over most of this. But the truth is whether you try to conceive on your own or through IUI or IVF, embryos do not fall out of you. Okay, there isn't anything you can do to unimpregnate yourself. If you have a healthy pregnancy, there's actually procedures people have to do to undo that. So let it go and understand that you don't have control over most of this. So that helps alleviate some of the stress, because again, I always believe that once I have a story where I had a husband and wife, and while the woman was in resting after her embryo transfer, the husband came out to me and he said, listen, she's got a really stressful job. Do me a favor. Can you write a letter so that she can take time off work? And I said, of course, I'll talk with her about that. No problem. So when she was done and came out and we spoke, I mentioned it to her. I didn't mention that he and I had talked, but that, do you need a letter? Maybe you need to be off work, et cetera. She said, oh gosh, no. If I sat home, I would just be thinking about this constantly and the stress would be through the roof. I need to go to work. I mean, yeah, it's a stressful job, but I know how to handle that stress. I'm fine there. So I need that. And that just goes to show you that really there isn't a single answer as to what handles the anxiety and stress. It really is up to the individual to understand that. So don't follow everything everybody else does and says. Think about what's going to work for you, but do release some of that control because you really don't have that much.
Great, thank you. One more for you, Nurse Linda. I have regular period and positive OPK every month, but I'm still not pregnant after a miscarriage. Any thoughts on that?
Okay. Well, I'm going to say the miscarriage probably doesn't have anything to do with the fact that we haven't been successful yet. You actually were successful. You certainly got to the point that you had an egg that fertilized and you had an embryo that became a blastocyst and implanted in the uterus. That all happened for sure. So we know what the sperm did. We know what the egg did. Now, what I don't know is I don't know the health of the embryo. That's usually the cause of miscarriage, even in younger women, is that you got to remember, we are born with all the eggs we're ever going to have. So even when you're 32 years old, even though that's a nice, healthy age to get pregnant, your eggs are 32 years old, whereas your partner's sperm was made just 2 or 3 months ago. That's why men can usually have babies till they're old and we can't. So the miscarriage usually is just due to an abnormal egg and therefore an abnormal embryo, and our body does what it's supposed to do. That isn't always the case. It can be a case sometimes where it's your body as well for a variety of reasons. But again, miscarriages happen. 1 in 4 women are going to have a miscarriage, and that's, I'm going to say, perfectly normal and acceptable, even a couple of them. Once we get to about 3 miscarriages or more, without a successful pregnancy in between especially, then I start to become a little bit more concerned. Don't know, I'm not sure by the question how long you've been doing the OPK test. Again, this is all kind of age dependent, but that's very good news that your periods are regular and that you're having regular ovulation. That just, and again, you obviously hit it once, so just keep trying because again, I have faith that, it'll happen again for you.
Okay, great. Thank you. And we're going to switch over to Steph. Okay, first question for you, Steph. We have a few for you as well. Spotting right before period. How do I fix this? Progesterone?
Okay, great question. And then this actually tackles a question that came in on the Q&A about somebody asked about, are there progesterone and estrogen supplements over the counter? I don't typically recommend any of that over the counter. So this kind of answers both to that person who's asking about should they be buying progesterone over the counter. I would not. Typically, we do prescribe a vaginal progesterone suppository for our patients going through fertility treatment cycles that they start 2 to 3 days after their insemination or timed intercourse at home. However, it's a compounded medication that we get from a special pharmacy. Vitamins, herbs, all of that over the counter, I believe in them. I take in fish oil, I do those things, but you also need to do a ton of research on making sure you're taking a quality supplement. And I'm sure Dr. Haebe can speak to that. Not all vitamins. And as a naturopathic physician, there's a big variety in buying something at Walgreens from XYZ company or ordering something that comes refrigerated and much higher quality. So be careful if you don't get sucked into this Chinese herb or this medication or supplement will help with the low progesterone. So one of the other questions was about a progesterone of 9.8 and spotting before your period. So just to give an example, I kind of drew something out here for everyone to see, and I'm not sure if it's going to be backwards for you guys, but this is what your hormones look like over the month. So this is going to be your estrogen. As your estrogen rises, that's follicle stimulating hormone. When your follicle grows, this estrogen is going to rise. It's eventually going to plateau. Then what everybody knows about on Premom is your luteinizing hormone. That's going to spike and come down. Now we've talked about on Premom, there's gradual surges, fast surges, but as that luteinizing hormone peaks, ovulation is going to be about 12 to 36 hours later for most women. It's very, very important to understand that your progesterone level has been low. So if you think of this as like a horse race, all of the horses are coming out of the gate at the same time. Estrogen wins the race in the beginning. Then it kind of just plateaus, goes steady. Then your progesterone is like, you know what? I'm going to catch up. So your progesterone surges. A progesterone level of 3 shows us that we're ovulating. It confirms that ovulation did happen. A progesterone level at the 9.8, don't stress that 9.8. It's no big deal. Progesterone levels are pulsatile. They will change throughout the day. So spotting before your period could mean a few things. It could mean that this progesterone level could be low. It could be 6 or 7. What your body's trying to do is that follicle that you ovulated from is now what's called a corpus luteum. Corpus luteum is pumping out progesterone, trying to help support a pregnancy. When we say we have a luteal phase defect, which was another question here, or a short luteal phase, that could come from a variety of things. If that corpus luteum is collapsing early and not secreting progesterone, it definitely could impact your chances of conception. That's why we across the board do put patients on a progesterone supplement after IUI or timed intercourse. And then just to kind of finish this up here, your body, if it does not detect HCG for pregnancy, everything kind of just drops right off and this whole process starts over again. So everything will come back down. So as your progesterone begins to drop, so this is here in your mid-luteal phase, once this starts to come back down, if your body's not detecting HCG hormone, then that's what's going to cause spotting. A few other things that could cause spotting prior to your period would be things like an endometrial polyp. This can cause irregular bleeding in cycles, sometimes fibroids in patients. If you are of the African-American ethnicity, fibroids are much more common and prevalent in that race. So if you find that, you're having irregular bleeding every cycle, it could be worth doing a saline sonogram to evaluate the uterine cavity and see if you have a fibroid that could be in the cavity of the uterus. This could also prevent pregnancy or decrease your chances. So things like endometriosis, PCOS, endometrial polyps, implantation bleeding, about 15 to 25% of women actually have spotting prior to pregnancy. So I will throw that out there. If you see some spotting the week before your period, don't panic. It could be some implantation bleeding. Some women have it, some don't. So just because you see some spotting, don't lose hope. You could still have a positive pregnancy test that month. But there's a variety of different things that cause spotting beforehand. Your luteal phase should be about 11 to 14 days. That's standard across the board. So if you talk about what makes your cycle different from my cycle, say my cycle is 34 days and yours is 28 days. the follicular phase in the beginning is variable amongst everyone. So Dr. Haebe's follicular phase is different. Nurse Linda's follicular phase is different. So that's what makes her cycle 28 days versus my cycle 35. But once she ovulates and once I ovulate, typically across the board, we're about 11 to 14 days until we either get a positive pregnancy test or until all those hormones drop off and we start our next cycle. So a short follicular or short luteal phase, anything under 11 days is, something to kind of look into and make sure your progesterone is adequate. But for that, the lady that asked about the 9.8, don't stress it. That's adequate. You don't need progesterone supplements over that. And then if you're spotting before your period, it could be a variety of reasons, but it can be completely normal as well.
Wonderful. Thank you. Is there, and this again is for Steph, is there a right time to baby dance and how often when the peak test shows?
Yeah, great question. So this actually, the question 8 and 9 from our people that submitted questions were very similar about timing of intercourse at home. So yes, there's definitely times that you want to baby dance or time intercourse at home. Really what we recommend is about day 11 to start trying in an every other day pattern. You don't want to be trying day 11, 12, 13, 14. It's too often. You want to give the sperm count a little time to recuperate in between. So about day 11, start trying every other day. And then when you get your peak LH test, I absolutely recommend trying that day and the following 2. If you can't do the following 2, then at least do the following day. Because like we talked about, ovulation is about 12 to 36 hours after that peak LH test. So day 11, we're trying every other day, just kind of casually getting sperm in the environment, making sure that, those sperm can live up to 5 days. So it's getting everything going in the right direction. And then when you get your positive test, say that's day 14 for your luteinizing hormone, definitely try day 14 and day 15. If you can, day 16, extra credit bonus. If not, no worries. Some people are like, oh, this is a chore at this point. I don't want to. That's fine. Always day of your positive LH test and the following day. A lot of people actually struggle because they get their positive LH test, they try that day, or they're like, oh, we tried yesterday, so I'm going to ovulate, and then they stop. Don't stop. That day 16 and 17 are still important.
Fantastic. And then we have one for Dr. Haebe. So we're going to switch over here. Dr. Haebe, is it normal to have multiple anovulatory cycles in a year?
Well, it's a good question. And I think normal is a tricky word, right? So average, typical, is it normal? Yes and no. Sometimes people do not ovulate every single cycle, and that's not hugely problematic, although ovulation is a sign of health, but some people do skip them sometimes. It depends on what else is going on in your fertility and hormonal picture at that time that's causing this inovulation. If it's chronic, if you're looking more at like something such as PCOS, then that's another pathology that we have to look into and really get to the root cause of. So again, I would say sometimes people will skip a cycle, but obviously it's a sign of health to get our hormones cycling properly to feel our best, because we even get our neurotransmitters are produced from our estrogen and progesterone. They make us feel differently. It's important for us to be ovulating. So the answer to that question is yes or no. It really depends on what else is going on in that picture and what that ovulation looks like for you and how your cycles are looking.
All right, fantastic. Okay, we're going to pick some of these. We're not going to get to all of them. Thank you so much, those of you who are out there watching, for submitting so many questions.
Well, let's see. We've got one here that says, how do you explain to your spouse that getting a sperm analysis isn't bad after trying for 4 years with no luck and doctor doesn't think it's a woman's issue? So this is an old age, or I should say age-old problem that men, rightfully so, it's difficult for them to try to give a semen analysis, and they don't like the concept of walking into a medical building and sitting in a room or bringing in a cup. That's all very difficult. The good news is you can do semen analysis at home now. It's just that easy. And trust me, they don't usually have a problem with that. So I would encourage anybody, since it's so easy now, to do that, because at least you can alleviate semen or sperm issues as being a problem. So go with that. Go with at least doing a semen analysis at home. Because again, if there's a big problem with sperm, this could take you right into assisted reproductive treatments. So you don't want to waste time.
Wonderful, thank you. Do you see another one, Nurse Linda?
Just reading. Well, somebody asked earlier, what's the difference between Clomid and IVF? So Clomid is an oral medication that is taken for about 5 days to help with ovulation, bring about a few more follicles. It can be done with just timed intercourse at home, or it can be done in conjunction with intrauterine insemination. So it's a medication. IVF is in vitro fertilization. That's the most advanced treatment you can get to try to get pregnant. And that is when the female takes usually injectable medications to grow anywhere from 10 to 20 follicles or eggs. And after monitoring, once they get to the right size, she will undergo a surgical procedure under anesthesia where vaginally with a needle, they'll withdraw or empty all those follicles and hopefully get a healthy egg from each. And then with sperm in the lab as well, they will make embryos. Embryos are created, grown for about 5 or 6 days. And then usually just one, sometimes 2 embryos are transferred back into the woman. And you wait about 10 days to see if it worked. That's IVF. But again, that's a procedure versus Clomid is a medication.
And while we're talking about Clomid, there's another one, and Nurse Linda, you can probably piggyback on this one as well. Are there any side effects to Clomid that aren't really seen? And just what I see is I do see issues with thin endometrial linings in women because it's actively kind of blocking those estrogen receptors in the uterus. So we don't get those thick, juicy cushion quite as much, especially when people have been on cycle after cycle after cycle of Clomid. Also, it does affect your cervical mucus a little as well because, again, we're messing with estrogen recepting. We're blocking some of those receptors to try to coax the brain into stimulating the ovaries to produce more of those follicles. So I think some doctors do have a preference towards letrozole. In addition to that, there are some ways of negating the effects of Clomid, not doing too many cycles of Clomid in a row, but also from an integrated perspective, there's some really good studies to support herbs like black cohosh and N-acetylcysteine to still support that endometrial lining throughout the process. So personally, I do see some people have some issues with it. I also see people get pregnant with it. So it's, again, that fine balance and finding what, drug is going to be best for you or natural method is going to be best for you.
You see, we also had a question about a short luteal phase and also about vitamins.
So I was starting to answer about the short luteal phase, which we talked about when we talked about the progesterone. This attendee had asked, what suggestions do you have for women who have a short luteal phase? If it's truly shorter than 11 days, we should draw a mid-luteal progesterone level and see what that level is. If it's less than 10, it's something that could be addressed. If it's over 10, it's typically not a luteal phase defect. About 15, 20 years ago, luteal phase defects were huge. Every practitioner was thinking that this was a big problem. And often they realized that it's typically not a luteal phase defect. So, if your after ovulation is shorter than 11 days, it's something worth getting evaluated. I would not take progesterone supplements over the counter. However, if your OBGYN or provider can prescribe you a compounded progesterone from a pharmacy where it's an organized fashion, remember you're putting this suppository into the vagina where you're hoping that it gets absorbed and everything. You don't want to just stick anything up there and hope that it helps that progesterone level. It can, the progesterone level comes from the corpus luteum, which is the area that you released a follicle or an egg from, that follicle. So if your follicle or your corpus luteum is collapsing early, that's something we would see on ultrasound. So if your luteal phase is truly shorter than 11 days, it's worth getting evaluated, talk to your OBGYN about it. But if it's in that 11 to 14 day phase, most people truly don't have a luteal phase defect.
Right. Fantastic.
All right. We had a question somebody asked regarding IVF. I had embryos that had 7-cell division, 2 fragmentation. Heading into cycle 2, is there anything you can do, natural or medication, to increase chances of a better quality egg embryo or help with implantation beyond progesterone that I should ask my doctor about? So that's difficult to say based on the information that you've given right there. That sounds like, I'm guessing, a 7-cell embryo on day 3. Generally nowadays, we always go out to what's called blastocyst, which is a day 5 or 6 embryo. That's going to speak a lot to the health of the embryo. Quite honestly, a lot of women, even women in their 40s, can make day 3 embryos that are usually between 6 and 8 cells. That's not difficult to do. But generally, you'll see the abnormal eggs develop into abnormal embryos trying to go beyond day 3. So you really should do IVF by going out to blastocyst development, which is a day 5 or 6 embryo. Now it's over 100 cells. So it's hard to say what 7-cell embryos really mean. Is there anything you can do, natural or medication, to increase chances of better quality egg embryo? It is true that the quality of the embryo is generally reflected by the health of the egg. That is true. There's a lot of opinions out there whether or not people can increase or decrease egg quality. There isn't anything strongly suggesting that there is a magic something that helps with egg quality. Certainly your general overall health and all of those kind of things, and supplements and exercise and good diets and all of that just help with our general well-being. But there isn't a special like, oh, take CoQ10 and your egg quality always goes up. It doesn't necessarily work like that. And again, sperm can impact embryo quality, but generally doesn't. It usually is an egg issue. So it depends on your egg and your age. And it does, next time I would recommend that your doctor go to blastocyst for sure.
Great, thank you. We have a couple more minutes before we wrap things up. Any other questions we can squeeze in here?
I'll just chat briefly about this vitamins one. What vitamins do you recommend while trying to conceive? Some doctors just say folic acid and a prenatal, and it becomes overwhelming because a lot of people are taking so many vitamins. And it's true. I think that the marketing towards women that are trying to conceive is kind of crazy, and you are bombarded by a lot of things and fancy packaging and pretty marketing. And this one's really important to me because just because it has a bunch of good things in it doesn't mean it has a therapeutic dosage in them. Additionally, just taking things just to take things doesn't necessarily fix anything. And as Nurse Stephanie touched on earlier, it's also all about quality. What are you actually getting what you're paying for? The good news, in my opinion, is that the FDA does not regulate supplements so that we can get what we want to on the market without having to go through FDA approval. The bad thing is that people can kind of put whatever they want and say whatever they want. So you really want to make sure you're kind of working with somebody who's well educated in the forms of supplements, the sourcing, the type, and even the transportation and care of those products in general. When it comes to a prenatal, let's just keep things basic. And I say always look for something that has a methylated folate, not just a folic acid, in case you do have the MTHFR mutation. It's one extra safety Band-Aid that you can do. And oftentimes if somebody has methylated folate in their product, it means they're looking into the research just a little bit more. Also, another really important nutrient that I think we're going to be seeing a lot more research coming out on is choline as well, to make sure that it contains choline. Additionally, I think always jumping on a fish oil, making sure you have really good quality DHA present, not just for decreasing your inflammation, but for supporting that little baby's brain as well. I would say in a perfect world, if you had to have two things, it would be a really good, robust prenatal, not one off the grocery store shelf that's the gummy, but something that has really well thought out ingredients. But again, I don't think you need to go crazy. Just focus on whole foods, take good care of yourself, lots of sleep, and just make sure you're getting that methylated folate with choline in your prenatal and potentially adding a good fish oil.
I'll piggyback that and say that choline is the best food for choline is egg yolks. So a lot of people don't eat the egg yolks anymore because they think their cholesterol is going to be impacted. That's been disproven. American Heart Association is not allowed to say that anymore. So don't, eat the egg yolks. An egg yolk, 2 to 3 egg yolks a day can pack in a ton of choline for you. So best food for choline is egg yolks.
Great. I knew we'd get some jump ons for that nutrition question. Fantastic. And we have some IVF questions. This is great. Everybody gets to talk about some things that they've worked on. Any other last questions before we wrap up here?
This one's a pretty quick answer about having one tube removed. Do ovaries alternate each month? They don't follow a schedule. It doesn't go left, right, unfortunately. Depends on with your surgery, if they remove the tube, if they left, any part of that structure, but if they completely removed the tube and left the ovary, you can actually still ovulate on the ovary without that tube. So say they removed your left tube and you have a follicle on your left ovary. When you release that egg, the egg can actually get picked up by the other ovary and follicle. So quick anatomy here, since I drew this out. This is your uterus, endometrial lining, fallopian tubes, ovaries. If you had one of these nixed and it's removed, if this releases an egg, there's actually little fimbriae here that come off this ovary that can pick up this egg and send it through this tube and implant into the endometrial lining. However, don't worry, if you have one tube removed, you can definitely still conceive. It doesn't mean that every other month you're doing a left-right. It's kind of just whatever happens.
Wonderful, thank you. And thank you all for participating. Thank you for those who are here watching and sharing your questions. Thank you, Nurse Linda, Dr. Haebe, Steph Kagan, nurse practitioner. And you can see all of these consultants right through the Premom app. If you go to more and schedule consultation, you'll see there are different categories for whatever you need. And you can find all three of these ladies right there in the app. So please be sure to check that out and schedule a consultation, particularly if we didn't answer your question or if you needed to go deeper with that. This is a great opportunity to really get some personal attention. All right, well, thanks again. You've all been wonderful, and you're not only amazing medical professionals, but you're fantastic speakers. So I hope we can do this again and have a wonderful rest of your day.